I'm Jeanne Holtz, and I'm the project manager with the ILO's Microinsurance Innovation Facility based in Geneva. I've been at the ILO since 2008. That's when the Microinsurance Innovation Facility was started. So we began after we received a grant from the Bill and Melinda Gates Foundation. And prior to that, I was in the private sector. I have a health insurance background. The transition from private sector to the ILO has been an interesting one for me. Actually, I'm able to use a lot of the skills and experience that I gained working in health insurance for as many years as I did. But the difference now is that I'm applying them for low-income clients as opposed to higher-income clients. I did have aspirations to give back more as a result of the good fortune that I've had myself. And it's been very fulfilling for me to go to ILO and work at the Microinsurance Innovation Facility. I think that it's also rewarding in the sense that I'm able to apply the skills that maybe are in high demand and are less prevalent in developing economies and in the microinsurance sector, and that is, commercial insurance and business skills. So that's been very useful. This topic of capacity building is something that we're talking about more and more. And what we've seen from the work that we've done in working through others and funding more than 50 different projects across developing countries, is that there's already a lot of knowledge out there. And yes, there is still a need to transfer knowledge from some places to others, but nonetheless, knowledge is there, yet people keep continuing to make the same mistakes. So capacity building is essential, and it's really putting knowledge into practice. And this is something that we work in now, and we see the need to work more in the future within capacity building. We're practitioner focused. So I think that, the needs are broad and diverse, there's no question, but basic fundamentals in terms of designing insurance products, knowing how to distribute them, how to price them, really all aspects of the insurance value chain, we can see a demand for capacity building. On the back end, claims adjudication and client servicing, all of these things. One of the things that I'm most proud of that we are doing and the way we are positioning ourselves is to be a hub for knowledge. So our aspiration is that we can aggregate knowledge and play a critical role in disseminating that. So as I said before, knowledge is out there, but it's somehow not getting transferred to the right people at the right time. So that's the role that we are playing and intend to continue to play. This is also, I think, a direction that we see a greater need for ILO to play. ILO, as you mentioned, is an active participant with policymakers. But when it comes to microinsurance, and because insurance is really at the crossroads between universal health coverage and private sector initiatives, and I think this whole facet of public-private partnerships is one area that we see ourselves being a neutral and prominent figure, and that we can play a role in bringing together these diverse parties.
My name is Cassie Wagner. I work with Health Insurance Fund, and Health Insurance Fund is an organization in Amsterdam which promotes private community-based health insurance schemes in Africa for low-income people. If you talk about the programs we have in Nigeria, we're talking about people who earn less than $1 a day. So, they are very poor. For those communities, they got to receive subsidies, for the premium that they pay. And then you have groups which are not so rich, but because they earn a steady stream of income, they can pay a considerable part of the premium. What we're trying to do is we pull in resources and risks. And I think is the future for healthcare in Africa, because if you consider the fact that Africa is home to only 10% of the world population, but has about 67% of AIDS cases, maternal death, women who die at pregnancy and childbirth, Africa has about 50% of those deaths. So when you look at those gloomy statistics, then there's no way that we could just let it be as it is, but come out with strategies which can support us fund healthcare. Now, one thing we have to bear in mind is, if you're talking about a long-term health insurance scheme, certainly you got to focus on different groups of people. So you have cross-subsidization, the rich subsidizing the poor, this healthy subsidizing the sick. So that's the basic principle. But you go to certain communities where people are just poor. We have a program in Kwara, in the center of Nigeria. People cannot afford to pay more than 10% of the premium. There you got to set up innovative financing schemes. So what we have there is that the people, they pay 10% of the premium. The state government has agreed to pay a considerable part of the premium subsidy. So you have the state channeling its resources through us because of the track record which we have there. And certainly, with the support of the donors, we could also do our best, to help subsidize part of the premium. You can make the case, the investment case, and that is good. Investment case meaning that you are pooling resources, at local level, whether from the people themselves, from the government, from private sector. You are pooling resources to finance healthcare. That is the big investment case. What, for me as an African, what I find stimulating is that this is a moment where we are engaging poor people who have never participated actively in their own development in terms of paying part of the cost. So that idea of stimulating self-reliance among poor African people is something that excites me. There are many challenges, but if, for the sake of time, if I have to name three, I will first look at the population. We go to a population, community, which has no understanding or limited understanding of health insurance. So they tell you, I will participate in it, but if I don't fall ill, I will come for my money. So insurance literacy, trying to educate people to understand that this is insurance, and it's insurance for you when you fall ill, that you can use it. When you don't fall ill, it's still important to participate. That is really a challenge. The second challenge I see is more at the policy level. African governments are very good at coming out with very stringent regulations, which definitely stifle the insurance industry. And I think it's important that we engage them also at the policy level to make them understand the need to have flexible policies which will stimulate the insurance market. And the last one, but not the least, is the administration of insurance. You go to a community, the local healthcare provider is used to receiving money and providing care. And then you go with your capitation, which he doesn't understand. You set up an administration system, to overcome fraud. Managing that and even identifying where people live, it's very challenging. And I know that in Kwara, we even went to the extent of numbering houses just to have a firm understanding of where people live. The policymakers should stimulate good governance, and that means ensuring, first of all, that they use their resources efficiently. And they also have processes, which will stimulate participation of private sector in the insurance industry in the countries.
My name is Dogo Muhammad. I am the immediate past chief executive for the National Insurance Scheme Nigeria. Professionally, I'm a trained urological surgeon, and I still practice. I have a practice in Abuja. It was almost at the verge of collapse in 2006. So that time I was with the Ministry of Health, and I was in the division of inspectorate. We are responsible for checking quality for the tertiary hospitals in Nigeria, both public and private, the teaching hospitals and all the tertiary hospitals. So I was sent there for 2 months to see if I can make, any miracle to sort of resuscitate. So 2 months translated to 6 months, and thereafter I was even appointed as a substantive executive secretary. So I hung on for another 5 years. So during that period, I saw the organization actually pulling out from its problems and then stabilized, and then tried to answer some of the expectations of the population. And then we are stuck in there because Nigeria has 3 tiers of government. And anything with a different governments that are autonomous, you find that if you have a national program, what obtains at federal level doesn't mean it will be easily accepted at state level because they are autonomous. So we have 36 states. Then it has to cascade also to the local governments. We have 774. So what started at federal level, initially people were skeptical that it will not work. Then it worked. Then people started asking, when will it touch my life? So we are forced to go ahead from the formal sector to the informal sector. So, and that's where actually I focus most of my, attention, trying to develop the products that will address the various segments of our society. And in Nigeria, the formal sector constitutes about 80%. And these are people who could be gainfully employed or not employed at all. And they carry the heaviest burden of disease. They are socioeconomically excluded. They have high index of diseases, and also the literacy level at that level is a bit low. And where they are residing also is in the periphery, not in the urbanized area. So 90% of the disease burden are there. The infrastructure is not there. And most of the people who should be giving them attention, the doctors, the nurses, the pharmacists, live in the urban areas. So you get a lopsided distribution of facilities and the human resource for health. And then the country is saying that we want to change our health indices. We have to crash them. There is no way you can crash them so long you are maintaining your presence in the urban areas. You have to, move to the periphery. So there must be a demand creation approach that will attract these young medical professionals to move to the periphery so that, people can get care. So that was a big challenge. It's not a problem of just human resource. There could be enough human resource for health, but the maldistribution. It's not about the physical, presence of hospitals and clinics, etc., but the distribution again, all lopsided in favor of the urban areas. So when people saw NHS was working, they brought all the problems of health and lumped it on this tiny organization that was grappling to maintain, some kind of presence and make a name, for itself, to say that, yes, we can do it. And we had a team that we believe we got to get it right. We believe that, yes, we have attained the critical mass in terms of commitment, numeracy, to take the agenda to the next level. So that's what we kept on doing. We developed the community-based social insurance scheme for Nigeria with 3 different models, implementation manuals, and then we went and did an inventory of existing mutuals, existing microfinance groups, burial societies, cooperative groups, etc., to serve as entry points all over the country. And then we set criteria and did some selection. Up initial, we wanted to select only 50 pilot sites in the country so that we can test for the next 3 years. We are privileged to compare notes with the other countries. We went to India, RSBY. We met also with the Micro Insurance Academy with Dr. Daror, trying to see, to learn. We went to Rwanda and saw what they were doing. We went to Uganda. We went to Mexico, Silva Cigaro. We went to Brazil. We all try to, collect experiences so that we can fast track this process. And the president launched community health insurance in Nigeria 17th December 2011. And along with it also, we address the demand side, because other Nigerians who have the financial muscle to flex are saying that we would like to have the same benefit package as those in the formal sector. So we introduced voluntary contributor program, same benefit package, and with IT solution for registration. You buy your voucher, scratch it, go online, register, get your electronic receipt, go to your hospital or the HMO, will take the biometrics, you have paid the premium, and you are up and running. The financing of this, whenever you introduce a new, product, there is a paradigm shift in financing health. And then you expect these people who you say are socially excluded to contribute. So that challenged us. And we're looking at other innovative ways. How can we mobilize resources? Nigeria has been grappling with our national health bill, to get it approved. It went through the parliament, came up for presidential assent, but because of some reasons, it was not signed into law. It expired. Okay, in that, if it had been approved, 2% of the federal consolidated revenue would have gone to primary health care. There were some professional, rivalry among the medical team. Some were complaining in terms of the leadership of the agency, that, there is a tertiary hospitals commission to be, sort of established, and it's part of the health bill. And then they were saying that it doesn't have to be a doctor, but then the document is talking that it should be a doctor. So that actually, and then other cries here and there. So, of course, a political environment, they have to listen to everybody. And that actually delayed. Then it overlapped. Then new, parliament comes into place. Then it has to go back. But if it has gone through, 50% of that 2% will be sent to the National Health Insurance to give cover. So when we didn't get that one, meanwhile we were thinking, and that's why we talk about this 1 kobo per second thing. And we thought it is a very brilliant way of mobilizing resources. When you take the oil, Nigeria is a one-product economy. Everything oil. But some 20 years, oil was not significant in Nigeria. It was more of agriculture and other, mineral resources. But today, about 90% of our revenue is from oil, and we have overloaded oil. So I think another thing is we have to allow people to take responsibility. It's not always for just government give, but what do you give to your country? So when you are looking at this thing, once you say it's about oil is not forever. It will get exhausted. So definitely there is a need. There is a need. We look at other ways of financing health, and we thought this one is a brilliant way of financing it because it will continue to increase. And I have seen it increasing from the time we had the idea, 80 million lines, to now 110 million lines, and they will continue to increase. So really we have to look at the ways we can finance different facilities or services to our people. And this is one of them. And I think it's user-friendly. Many people who are talking, buying, scratching upfront and talking, don't even care how much. They wouldn't know you are paying a kobo per second, which is contributing to health. And I know health. Another thing which I want to say maybe a little bit outside what you have asked me is we have overflogged the issue of financing health. And when you look at it, it is all about curative. But there are other collaborations, outside health that could make a difference. Take water. 60% of communicable diseases are waterborne. Give people good drinking water. That thing will crash. When you talk about the environment, the drainages are blocked. Stagnant water, that's a breeding place for mosquitoes. That's the vector for malaria. 50% of our disease burden is malaria. Clear that. Let the water move. Let us destroy all the breeding places. Malaria will crash. You understand? So these are some of the things that we have to see collaboration. Ministry of Health, Ministry of Environment, Ministry of Finance, like that. Ministry of Water, Resources and Sanitation. So that we reduce the burden of disease through preventive methods and other infrastructural solutions. And then good living, health talks, etc. Preventive thing, immunization, etc. With that, all the disease burden will crash to the barest minimum. Then whatever little money we have, we can be able to treat the diseases. So this is what I think we should be looking instead of overflogging. And when you talk about curative, then you have those people who are in the primary health center or in the primary environment talking of the tertiary is too expensive. You know, you put so many, but you allow people to get sick. You can prevent them from getting sick.
My name is Maria Helena Bidino. I work for the National Insurance Confederation in Brazil. We deal with all kinds of insurance, and my role there is consumer protection, microinsurance, international affairs are the main subjects. Countries like Brazil, we have a very huge amount of population that is lower class, and insurance is a tool that can protect them for vulnerability. And health insurance is the main product that anybody from different classes, but mainly for the poor people, they look for. And in Brazil, we have public health insurance protection, but the government cannot give them the quality and the speed of the services they need. So we also have the private insurance and plans and insurance company providers. We have both for both systems. The public, everybody is covered. The private sector covers more than 60 million people nowadays. But it's getting very expensive. So individual plan insurance is very difficult to find because it's getting too expensive. The government interferes in the price also. So nobody is happy. The population is not happy. The hospital, the doctors are not happy because they receive a very small amount. So you go to a doctor, they even can look at your face because they don't have time. So sometimes it's better the government treatment, although it takes time to receive it, but you have doctors that are there for this purpose. So it's very challenging. There is a lot of regulation, very heavy regulation, and we are afraid, as your deputy minister announced here, that too much regulation also can dismantle the small providers, and that is what can happen in Brazil. Regulation is the most challenging, and they should have more dialogue. The government with the private sector. We are in the same boat, and they should, even the private sector should listen the challenge of the government and the other side too. Should be more dialogue. And they want to protect so much the consumer. They are feeding the market with so many regulations and so many laws that is a costly consumers, because at the end of the day the consumer pay the bill.
I'm Segi Pillay. I'm from South Africa. I'm the Chief Executive of the National Health Laboratory Services. My own country, there's a big discussion and debate right now around the introduction of a national health insurance scheme. So we just got the green paper out. The Minister of Health has just put out a green paper, and all of us, including my own organization, are now beginning to take the first steps towards the implementation of some form of health insurance. The key issue is that the question of providing comprehensive health care for the citizens of particularly developing countries is possible if people apply their minds in a very strategic way. And I've seen many examples today of how small groups of people in partnership with governments and involving the citizens and beneficiaries of the program have been able to set up small and hopefully slowly can scale that up. So just in terms of the kind of key lessons here was the one is that it's becoming increasingly obvious that governments alone can't provide for the healthcare of all its citizens. There's a big question around an economic environment that makes it very difficult, but also with the competing needs of a country, choices have to be made. And I think one of the options that are available to us is that every citizen, from a human rights perspective and certainly from my country, from a constitutional perspective, has a right to healthcare. But I think that there are models in which the citizens and government can work together to provide the financing base to deliver the kind of quality healthcare that people deserve. Many countries are trying to achieve the same thing. So the destination, the final destination is going to be the same, whether we're in South Africa, whether we're in Nigeria, whether we're in Ghana, whether we're in the Philippines. But obviously there are different routes that we can take to achieve this universal coverage. And there are important lessons for us to learn, both from industrialized countries like the Netherlands right now. There's huge successes, but there are also some weaknesses. I'm hoping that we can leapfrog stages of development. I hope that we don't have to walk every stage that the Netherlands, for example, went through. So I think from where we are sitting at the moment, there are opportunities for us to achieve much sooner what many of the industrialized and developed countries have taken a much longer time for us to achieve what we wanted to set out to do. So from that perspective, I think that there's no right model for any country. That's what I'm hearing from the presentations today. But the key issue is that whether you're starting off big, whether you're starting off from the top, or whether you're starting off from the bottom, really doesn't matter. I think it really depends on what is the economic base of the country and what is the skills base and what are the systems that we have. So while my own country may be choosing national health insurance scheme, and it basically is top down, but we've seen the examples in Nigeria, we've seen the examples in Ghana, we've seen the examples in the Philippines, for instance, where around small communities you slowly built up the base. But the important lesson from all of this, whatever small community-based alternative is set up or insurance scheme is set up, in the end, it must all be integrated in some kind of national universal coverage for all of the citizens of the country. The key issue is that there are a lot of innovation within communities. And even in poor communities, what we're learning is that people have resources. They may not have huge amount of resources, but they have some resources. And I think that if there are creative ways in which those resources can be pooled, then I think the lesson for policymakers is don't automatically assume that people don't have anything. Pool, whether it's the $1 or the 50 cents, but once you pool that, suddenly the problem doesn't seem as big anymore. But if you're looking at an individual and trying to respond to the individual, then it seems like it's insurmountable. So I think that's the first aspect. The second aspect about policymakers is allow these small pilot projects to evolve. Because out of these pilot projects, you learn both successes, but you also learn what you shouldn't do again. So I think that's the second side. And the third side is that it's important that governments all over in developing countries begin to create the legislative framework for all of this to happen, because you also don't want a national health insurance scheme. People contribute to that, but they actually don't get the benefit. And the benefit is really about providing affordable healthcare to the citizens. The objective of universal health insurance is not about collecting money. It's about ensuring that we can finance the healthcare that citizens are not getting right now.
I'm Sanjay Datta. I'm the Chief of Underwriting and Claims in ICICI Lombard, the largest health insurance company in India. We've developed a lot. We're a $1 billion company now. We've grown in various aspects of general insurance. But the biggest product with a lot of potential is health insurance. The market is growing very fast. Till last year, it was growing at 35% CAGR. And we work in all the three segments, which is the retail, corporate, as well as the the insurance for the rural poor. We are one of the biggest insurance partners with the government for their financial inclusion programs. So there are 2-3 schemes which we run with the government. One is National Insurance Scheme for the poor, which is smart card-based scheme which we run for the government. We believe access to quality healthcare at affordable prices is a fundamental right. As fundamental as human rights, actually. And, to play that part, I think, insurance has to play a big part in providing that access through financial mechanisms which work for such an access. And, India is a billion people, and most of them are very poor. And it's important for us to make sure that our processes and the kind of insurance products we develop for them are work on efficiency, which is technology-based, where the costs are very low. The product is, has a high utilization rate and is sustainable in the long run. So that's what we've been working for. And of course, scale is an important part. And while we understand scale, we also feel that there's a need to customize products according to the various regions of India, because India is a union of about 28 states. In India, about 60% of healthcare costs are met out of pocket for outpatient treatment. Most of the health insurance products are for inpatient treatment. For a certain, group of privileged people who work as artisans and weavers, we developed a scheme where the lead product is an outpatient product, where the utilization rate, went up significantly once we adopted technology-based processes with no paperwork. And the scheme has started working very well. The enrollment rates have gone up, the retention rates have gone up, and it's all hinged around outpatient sort of clinics which work near the doorstep of the community. So we've innovated a lot in health insurance. Not only have we innovated in terms of processes, but also products. So we've brought in a lot of products which are, first in terms of, in all the segments of the, the population. So we've, brought in concepts like, floater sum assured for the families. We brought in concepts like, having outpatient treatment included as part of, the inpatient coverages. And of course, we worked a lot on, other products which are, like critical illness coverages, which are linked to bank home loan products, which normally have a lot of loss of income sort of elements to it. So, we devised a lot of, critical illness products or, hospital daily cash products. I believe, that, insurers have to play a big part in, financial inclusion, given the fact that India is a very, very undersaturated market, and we can leapfrog, through the learnings of all the other countries in terms of what they attempted and what were the good practices, which we can bring, forth for our country and maybe for the population which we serve. Access to these kind of conferences also helps a lot to pick up ideas, good ideas across the world, which we should be able to bring across to, good quality access to healthcare through the insurance system. Big idea, of course, is the fact that one needs to collaborate a lot. Healthcare is a complex system where every part of the social system is involved, including health policymakers, the academics, and various other sort of bodies. In fact, I was just mentioning to the director of ISS that a lot of the policymakers or people in academia are like navigators to us while we drive the car. So they help us a lot in driving in the right direction, because a lot of the thing is unknown. We are charting new territories, and that's where we need a lot of navigators to help us to drive correctly. I think they have to focus on the fundamental part, which is health risks. health risks are as important as I said, fundamental rights. There needs to be mechanisms where health risks are properly pooled, at least the ones which cannot be borne by the individual in the long run. And the second and the most important part is, while we call it insurance, at the end of the day, it should seem like assurance. They need to, keep healthy, you remain healthy. In case something happens, there is someone to take care of things.
I'm Fola Laoye, chairman of HYGEA, which is an integrated health group in Nigeria, working with the Health Insurance Fund to deliver health insurance to low-income groups in the country. HYGEA was formed almost 30 years ago by my parents, who are both physicians, who also had their careers in the public sector and in public health. Then, after they retired, went into the private sector, but still very much having the motivation and the commitment to helping to deliver public health services. We are able, at least in the work we're doing and with the partners that we have, to look at the very difficult issues of delivering public health services, but from a private perspective, which is quite unique and quite innovative. But in so doing, helping to bridge the gap between affordability, what people can afford, and what is the cost of healthcare. I think for me, one, growing up around the business and also where we got to, I did realize that there was a model to be sustained, that could be built and could be sustained and could be taken to scale. And I often think that in the private sector, we are able to sometimes be a bit more nimble and a bit more proactive in terms of looking at innovative ways to solve problems. Nigeria is a country that has large population and very poor health indicators, so that in itself is a problem. But going beyond that, also trying to build a health system for a country that's very disparate, that has many different cultures, very, geographically disparate, is quite difficult. But particularly made more difficult because of challenges of infrastructure, of human resources, of real capacity. And that's something that, health, needs to really be successful and viable. We do want to see stronger political will, one with a government putting a better financing structure for healthcare on the table. We are still severely underfinanced as a sector, but even apart from the financing, the regulatory side of it still needs a lot of work, needs a lot of commitment, needs a lot of capacity. And, and especially if the private sector is going to play a bigger role, it's very important, again, that there's a regulatory framework that governs what the private sector is doing. So, yes, it's an area that, is still nascent. And I, for one, I'm very hopeful that this current government will do a lot more. One important area is what is the cost of healthcare. So yeah, it may sound more quantitative than qualitative, but in a way it's linked because that also really gets us to understand what are the disease prevalences we're dealing with now. We all have heard and seen the numbers globally and even Pan-African for the incidence of non-communicable diseases and what that impact is on health systems. But I don't think we have done enough work and gathered enough data in Nigeria to be able to really holistically say, this is what it's going to cost and how do we tackle that. The work we've been doing with the Health Insurance Fund has actually almost brought that even more to the fore than we had thought it would.